Dear friends, it's a pleasure to be with you today at that ISG webinar on metabolic syndrome in women and what they can be the impact of metabolic syndrome. We will have today the pleasure to have our president, Professor Tommaso Simoncini, which is, we will speak about the reproductive impact of metabolic syndrome. And later on, Professor Andrea Giannini will speak about oncological impact of metabolic syndrome. As you know, this is a fantastic area which is of huge importance as metabolic syndrome impact a very large part of the female population, and overweight and obesity are also an actually present all over the world and impacting the world. The first speaker is Professor Tommaso Simoncini, who will speak about of the reproductive impact of metabolic syndrome. He is the president of the ASG Society, professor of OBGYN at the University of Pisa, and head of the OBGYN division, with over 380 scientific papers. They're rising every time, Tommaso, my compliments, and more than 14,000 citations. He has received numerous scientific awards, including the Merck Senior Fellow and the Robert Greenblatt Award. Tommaso, you have the microphone, and if you can share.
Thank you. Thank you so much, Professor Genazzani. It's fantastic to be here with you and with Andrea Giannini. And let me share my screen and start right away with the presentation. I see we have a very large audience today, so I hope I will be able to enjoy you with the presentation. So reproductive impact of it's not the menopausal syndrome, it's actually the metabolic syndrome. I'm sorry, when I wrote the title, I was in my menopause mood, evidently. So sorry for the mistake. But anyhow, so this is a short view of Pisa, where I work, where Andrea works as well, and where Professor Genazzani has worked for many years. Now before moving to Rome, to the eternal city. The disclosures, and let's start with the introduction. So I'd like to spend some time talking about metabolism, and by doing that, I need to start by talking about insulin, because insulin is the multifunctional hormone that is so important for metabolism. So insulin is a hormone that is recognized by a membrane receptor, the insulin receptor. And through this receptor, insulin plays direct actions on the fat and effects which are actually played on metabolism by working on different tissues. So on your left, you see the signaling cascade, insulin binding to the insulin receptor, activating the insulin reactive substance, activating PI3 kinase, or phosphatidylinositol 3 kinase, which then starts a number of events culminating in the activation of AKT, or protein KC, which is the signal transducer in many cells. And as you can see, in fat cells and also in muscle cells, there's a lot of things that have to do when this signaling pathway is activated with glycogen synthesis, lipid synthesis, gluconeogenesis. And when insulin arrives, you have a stimulation into the synthesis of glycogen and lipids, and a reduction of gluconeogenesis, so the formation of glucose inside the cells. But as I said, there's also some indirect effects. So insulin is able to regulate glucagon secretion in the pancreas. It's able to modulate lipolysis in the fat tissue, and it also works on different centers in the hypothalamus. So it's also important as a sensor for satiety, hunger, and it's very important in modulating in the end overall metabolism. And of course, it has a whole lot of effects on the liver. So the crosses are where the insulin works by activating, inactivating, but mostly they are meant to depict what happens in people who are insulin resistant. So when we discuss about metabolic impairment, the first feature of people that are metabolically impaired is that they are resistant to the effect of insulin. So all these very important and powerful metabolic actions of insulin are not working properly in insulin resistant person. So what are the consequences of insulin resistance? So on the left, you see what do we do mean and how we construct the constellation of features of the metabolic syndrome. There is not just high body weight, but mostly increased waist circumference. So it's abdominal fat, which is the hallmark of the metabolic syndrome. There's lipid derangements with increased levels of LDL cholesterol and decreased level of high HDL cholesterol and high triglycerides, which is very bad, particularly in women. It's really the combination of lipid derangement that increases cardiovascular risk. And on the other side of the graph, you see high blood sugar, so the tendency towards having higher sugar levels and higher levels of blood pressure. So all these conditions are very important, and if they put together, they can pull together. They can happen in different situations. For instance, PCOS is a condition we know very well being associated with insulin resistance, and therefore it's a condition that facilitates the development of metabolic syndrome. But pregnancy as well. We know that pregnancy is a condition where there's a number of physiological changes which increase insulin resistance. And both these conditions can, one in the long term, like PCOS, the other one during pregnancy, can lead to development of diabetes. So a condition where the control of blood sugar is lost, and therefore the individual who is exposed to this condition develops diabetes. Now, what is actually very important is that metabolic derangement seems to have many predisposing factors. And one of the most important could be the epigenetic predisposition, not just the genetic, but also the epigenetic. So, not just having a familial predisposition, genes that make you more prone to develop abdominal fat or to be less efficient in transducing the signaling of insulin into cells, but also how you are exposed to metabolic conditions during pregnancy can actually predispose the future metabolic behavior. So between the status of embryo, a fetal life, and postnatal life, you can see that there's many conditions like the organization of the tissues, the remodeling of tissue, the endocrine functions which happen inside the pregnancy, and the equilibrium between the lean muscle mass and the fat mass that are influenced by the metabolic environment of a pregnancy. So being born by a mother who develops diabetes, who's obese, who's insulin resistant, can probably have a long-reaching consequence for also for the offspring, so for the newborn. And we think that the scientists who are into this field think that there's a critical window for the development during which there is how much tissue, how much fat tissue is formed is determined, and the absolute number of adipocytes is something that can be largely determined prenatally. But the other thing is also how the pregnancy develops. So the metabolic derangement of the mother has an influence on the fetus, but also the fetus can be exposed to a condition of dieting, let's say, when the placenta particularly is not that efficient, and there's a restriction of the fetal growth during pregnancy. Then on the other side, the fetus becomes programmed to be over efficient into absorbing nutrients, particularly glycides and lipids and proteins. And this makes it such that once the fetus is not a fetus anymore, it's born, so it's a baby, um, he or she are extremely efficient in reaccumulating because their metabolism has been preset to be very, very fast. And there's this catch-up growth, that's how it's called, after birth, that turns into an accelerated growth, which programs the fetus, the newborn, for being more prone into transferring nutrients into fat, and therefore this can have long-term consequences into making these individuals more efficient into accumulating fat storage, and therefore becoming eventually insulin resistant, because the amount of fat that we have is a predisposition to insulin resistance. So Professor Barker, several years ago, back in the 90s, advanced this hypothesis, which is largely known as the Barker hypothesis, which identifies conditions which are experienced by the fetus during pregnancy inside the mother's womb as a programming for cellular energy metabolism, particularly for glucose handling, lipid metabolism, and mitochondrial biogenesis, that can determine how the relevant metabolic tissues, adipose tissue, muscle, liver, the pancreas, the cardiovascular system, and the brain, particularly the centers in the brain, which determine leptin resistance and lipid accumulation, how they will work in the future during adult life. So this is very important, and there's many indication that this is true. For instance, there's a number of maternal and early determinants of insulin resistance in offspring that have been demonstrated as an association. For instance, maternal obesity, gestational diabetes mellitus, we've talked about that. A fetus that is large for gestational age, therefore, has the ability, not just because of the maternal diabetes, but because of predisposition to accumulate and to grow faster than usual. And also the breastfeeding, meaning inefficient breastfeeding, shorter breastfeeding, are all determinants of insulin resistance for the future life. And for us, we're gynecologists, so we want to dissect when metabolic issues should be important for us when we follow the growth and we treat our women during life. So we have two different types of situations where we might be particularly interested in terms of insulin resistance. For instance, those girls who are extremely thin at birth and who then become tending to be PCOS women, they tend to be insulin resistant even if they're not obese or even if they're not overweight. So this is a population where genetics and probably programming predisposes to insulin resistance, such that you don't even need to be overweight. And this is a special population because we know that they exist, but in our general practice, we don't expect and we don't think about insulin resistance or metabolic derangement. And we know how important this is, not just for the metabolic issues, but also for the reproductive impact. So ovulation, fertility, and so. And on the other side, of course, there's the overweight or obese women. So here we have a clear-cut situation where we know that there's a number of reasons, including sedentary lifestyle, diet, that add to maybe the peculiar genetics or predisposition in terms of being more fat than other individuals in terms of determining insulin resistance. Now, when we talk about PCOS, you all know that PCOS and metabolism are, go hand in hand, and there's at least 75% of PCOS who have a phenotype which includes an impairment of insulin action. Now, we all know that's also dependent on how these women behave in their life. So they might be predisposed, they might be tendent to be insulin resistant, but of course, if they have a high hyperandrogenic milieu, and if they also have a lifestyle that favors insulin resistance, so they're not physically active, they don't increase their muscle mass, they have a diet that helps them into accumulating fastly available nutrients like simple glycides or lipids, then everything goes hand in hand into determining adipocyte dysfunction and into determination of insulin resistance. So it's somehow hard in some cases to say whether it's because these women get additional weight, whether they're not active, whether they're hyperandrogenic and therefore they become insulin resistant, or if it's the other way around. So insulin resistance is a part of their peculiar hallmark, so how they're programmed, and therefore they become hyperandrogenic because we know that insulin resistance in the ovary stimulates the synthesis of testosterone by the androgen secreting cells in the TECA cells. So when we have in front of us a woman that has PCOS, and we know she's predisposed or she has PCOS, if we see that she has an unhealthy lifestyle, environmental factor that facilitates the development of this condition, we need to be aware that if she becomes insulin resistant and she becomes hyperinsulinemic, then she will be in trouble. And she will be in trouble because it's going to be very difficult for her in moving away from a vicious circle in which the resistance to insulin and the higher levels of insulin tend to drive fat accumulation. And even she works out a lot in the gym, even if she diets, then she will have more trouble than other person in losing weight. And so we need to be very aggressive into providing cures and combined oral contraceptives or anti-androgenic progestins are very good into blunting and curing the not just the skin effects of the hyperandrogenism, but also the metabolic effect of a high testosterone level on insulin resistance. And on the other side, we need to be aware that some women need some help, some metabolic help, and therefore the use of inositol or the use of metformin are well established into facilitating their first steps into the virtuous path towards losing weight, becoming more active, and therefore getting back in track and being able to engage again in a healthy lifestyle, particularly including physical activity. So when we think why should there be an insulin resistance in a woman with PCOS who has normal weight? Now there's many reasons, and basically there is signs that those who are thinner and are PCOS women, because of a number of conditions, they have different adiponectin levels and abnormal pyruvate dehydrogenase regulation. These are pathways that induce a reduced insulin sensitivity and a decreased efficacy of insulin to working cells. So there might be things that happen inside the fat and other tissues, but particularly inside the fat of this woman that predispose them to be particularly efficient in not being insulin efficient. Let's say. Sorry for the word joke. Um, then there's another thing that is less appreciated, but that's becoming more and more important, particularly in the field of hepatology, or the relationship of insulin resistance and the development of liver disorders, and particularly the development of non-alcoholic fatty liver disorders. Now, NAFLD is a condition where there's an increased deposition of fat inside the liver, which is part of a complex process, which when added to other conditions, helps the liver to work less efficiently. And this is very important because particularly in over-industrialized countries where there's over treated food available, non-alcoholic fatty liver dysfunction is something that is becoming more and more important. And this is a diagnosis that can be made sonographically. And there's a direct relationship between insulin resistance and the development of a non-alcoholic fatty liver disorder or disease, which is direct. So the more you're insulin resistant, the more you develop this fat deposition in the liver, which is, as I said, one of the most important risk factors for future liver disease. Now, pregnancy. Pregnancy is the other condition where we gynecologists are so important in terms of identifying, preventing, or treating metabolic disorders. And it's important because it's important for the mother and for the fetus. So when we have a woman that is at risk of developing diabetes mellitus, of course, we know that we need to do something. We know that women who are obese or overweight or have additional risk factors like having had a previous gestational diabetes or being hyperinsulinemic or actually insulin resistant before pregnancy are at increased risk, while leaner women or those women who accrue less weight during pregnancy are less frequently affected by diabetes mellitus, although we know that there's a significant amount of women who are lean and have no risk factors, and that's about 20%, at least in Italy, who develops diabetes mellitus, even if they don't have risk factors. So this is something that we need to take into account. Therefore, screening programs are well established, and we have very solid guidelines to that effect. Now, it's not just how you are obese or lean before pregnancy, but it's also your ethnicity, your genetic backgrounds, your familiarity, so the familial predisposition, but also the fitness levels. The fitness level is extremely important. So if a woman enters into pregnancy being physically active with a physical performance which is fine and continues throughout pregnancy, this is probably the most important factor that will help preventing gestational diabetes. And why is it important? It's not just because of the well-established complications of pregnancy, but it's well known that women who are insulin resistant tend to have higher rates of recurrent miscarriages. So identifying and adjusting metabolic disorders is a part of the workup of recurrent miscarriages. And there's many reasons for this. Let me go fast because in the interest of time. But the other part is, of course, all the impact that the metabolic derangement carries in terms of cardiovascular risk during pregnancy and for the future of that woman's life. So we know perfectly that insulin resistance is associated with hypertensive disorders of pregnancy, particularly with preeclampsia, and it's in both directions. So having insulin resistance predisposes to hypertensive disorders of pregnancy, but also women who have experienced hypertensive disorders of pregnancy tend to be more frequently insulin resistant later in life. So we go back to the constellation of things that make the metabolic syndrome. From the moment of pregnancy, we can identify those women who later in life might be more prone to develop cardiovascular disease. And these are the women where we need to be extremely effective into explaining their future risks. And then women go through their life, and they reach perimenopause and menopause. And we know that this is another part of a woman's life that we as gynecologists associate with issues like insulin resistance and fat accumulation and metabolic derangement. And this is for many reasons. On one side of the slide of this nice women's cartoon, you see that metabolic efficacy gets worse, of course, with life. It happens to all of us. There's nothing with aging that makes you better, in particular with metabolism. Um, and on the other side, you see that there's also other things which are associated with the menopausal transition that have an impact on metabolism, particularly sleep disorders. Sleeping less efficiently increases cardiovascular risk, increases blood pressure, increases insulin resistance. Depression is well established to be associated with food craving attitudes which are not efficient in terms of metabolic health, and of course also having vasomotor symptoms. Those women who have strong and early vasomotor symptoms tend to be very metabolically impaired, more metabolically impaired than those women who don't have vasomotor symptoms or have very few. So you all know that menopause starts in the brain. So the brain is the principal reason why women develop symptoms of menopause. And there are so many things happening in the brain that are associated with changes in the secretion of neurotransmitters, like the ones you see on the slides. And one of the things that you may not be completely aware of is that also the feeding center and the satiety centers, so the centers that make a woman feel hungry or not hungry or full, are heavily impacted by these neurotransmitters. And these are the neurotransmitters that tend to be deranged because, or during the menopausal transition. And indeed, what happens at the time of menopause, which is a clinical experience of all of us, is that most women, not all women, but most women tend to see a change in the body shape. And the traditional accumulation of fat, which is generally into the legs or the lower part of the body, tends to be shifted towards the abdominal fat. So this is very important. Data from the study of women's across the nation, the SWAN trial, which is a very important study that has followed women throughout many, many years in the United States over and beyond the menopausal transition, show that the odds of developing metabolic syndrome per year is 1.45 in the perimenopause and 1.24 after the menopause. And this is associated with many endocrine changes that we know being associated with the menopause. But you see how interesting it is. The risk is higher during the perimenopause and becomes still increased, but less increased after the menopause. So if you look at the graphs from the SWAN trial, it's very interesting to see that women that go across the menopausal transition, you see the zero here stands for the year when women stop having menstrual periods. So this is before menopause, and this is after menopause. So what you see here is that there's no increase in body weight, no increase in the percentage of body fat, but there's an increase in visceral adipose tissue and subcutaneous abdominal adipose tissue. But you see, if you look at the slide, the graph, you see that the increase in distribution on the visceral district increases much well before the final menstrual period. So it's not losing estrogen, it's the brain changes that happen approaching the menopause that predispose to this visceral, to this fat redistribution towards the abdomen. And this happens with, in parallel of a decreased total caloric intake. So women notice this accumulation of fat in the abdomen and therefore try to diet. This is, of course, our experience whenever we see ourselves getting weight in front of our, the people tell us, let's say, we tend to be more aware. We did a study a few years ago together with Peter Chedraui in Ecuador. Julia Palla, who was working in my lab at the time, was the PI, where we measured more than 100 women across the menopausal transition, assessing them pre, peri, and after the menopause. And it was extremely important and interesting to notice that between about 100 molecules that we knew being associated with insulin resistance, there was some changes in the biochemical markers of insulin resistance, which would be associated with less insulin sensitivity. So this would make their metabolism worse, but also some of the changes were actually positive in terms of metabolic derangement. For instance, many women had more adiponectin and augmentin 1, in theory, increasing insulin sensitivity, telling us that metabolic changes at the time of menopause are more complex than just becoming insulin resistant and hyperinsulinemic. Indeed, if you take the time and go and study how fat accumulation is driven mostly, you will discover something very funny, that if you look at the number of stars into these graphs, the more stars indicates the district or the phenomenon which is more important to drive fat accumulation. And you see that the more stars are in the brain and in basal metabolism. Allora, energy balance or basal metabolism is how much we burn of the energy that we get into our body with food. And throughout aging, we burn less and less and less. And that is so. That this is why when we are very young, we can eat whatever we want and we don't get obese. But then after a while, we tend to see that with the same physical activity, with the same diet, we tend to accrue fat. And the fat is our friend indeed, because fat tissue is the place where the excessive glucose and lipid that stays in our bloodstream because we don't use them to make energy can be stored. And if you don't store it there, then you become diabetic or you have a lipid derangement. So up to a certain stage, the fact that we decrease our energy balance or how much we burn is offsetted by getting and hiding the energy, excessive energy in the fat. But after a certain stage, the fat becomes the reason why we become insulin resistant. And then also insulin metabolism becomes important. And why is it important? Because particularly throughout aging, so after the age of 50, our cardiovascular risk becomes more important. And it's very well established. If you look at this graph from the InterHeart trial, you see that if you compare the risk of dying for myocardial infarction, there's a clear association both in men and in women with the waist to hip ratio. Which is much more relevant and visible than the risk associated with the body mass index. So it's really not how much we are fat, which is important, but it's much more important if we are fat on the abdomen. And in this review that Professor Genazzani coordinated together with Patrizia Monteleone and Andrea Giannini a few years ago now, I think it's a very nice paper. You should go and look into it. Should be now open access to see how the weight and the metabolic changes are integral part of the metabolic transition. And they're integral part of the reasons why a woman throughout menopause loses estrogen, has a worse metabolism, and therefore increases her cardiovascular risk. With the development of the cardiovascular lipid profile, which is very, very dangerous for her, so that low HDL cholesterol, high LDL cholesterol, but particularly high triglycerides, together with hypertension and potentially diabetes, are the real killer for women. And these are the numbers. So in Europe, this is a study that dates back to 10 years ago now, it's the DECODE trial, about there's a doubling with about 14% of, actually 11% of women across the time when they get menopausal who qualify for being affected by the menopausal syndrome or for being hypertensive. You see from 20% to more than 40% between the age of 45 and the age of 64. And this is very important to be understood. Becoming heavier, becoming hypertensive, becoming diabetics has not the same impact in women as it has in men. If you look at the impact of having hypertension or diabetes in men or in women in the DECODE trial, you will see that women, if they're hypertensive or they have diabetes or they have both, it's more or less the same. They have an increased cardiovascular risk. But in women, the two risk factors build up, they synergize. So the risk doubles up when you get together diabetes and hypertension, because women are more vulnerable to these conditions, and they are much more vulnerable the earlier they get menopausal. So this is a very nice paper published back in 2019 showing how menopause before the age of 40 as compared to the age after 40 makes an incredible difference in terms of the risk of developing hypertension, hyperlipidemia, and type 2 diabetes. So it's really a condition that should be taken seriously. And when we talk about menopause, of course, we have an everlasting discussion on if whether hormone replacement is good in terms of many things, including cardiovascular risk. We do have quite interesting evidence, large evidence showing that women who receive hormone replacement therapy when they get menopausal tend to accumulate less visceral fat. This is a big cohort published now in 2018. It's a multinational cohort where you see the lighter green indicates women who are currently receiving HRT between the age of 50 and 80. Those in lighter green received it in the past, and those in darker green never received the HRT. You see that android fat, visceral adipose tissue are clearly less present in those women who have been receiving HRT or are currently receiving HRT. And in the same trial, there's a number of parameters that indicate that those women who are current users of HRT better than those who were past users, who are anyhow better than the never users, are better in terms of glucose metabolism. And then we have a number of papers, a very large number of papers showing that HRT after menopause is very good for metabolic issues. It prevents diabetes. It's probably the only treatment that prevents diabetes in women who have not diabetes. And in women with diabetes, it also helps establishing a good compensation, a good insulin status. And of course, we have plenty of data that women receiving HRT starting early after the menopause do much better in terms of dying or having a cardiovascular attack. And these are the data from the Danish osteoporosis prevention trial that I showed in the previous slide, and from the Women's Health Initiative trial, both showing the same theme. Particularly the WHI trial is very important because it's a trial, let me remember it, performed in women who are largely heavily overweight, hypertensive, diabetics, and nonetheless receiving MHT after, particularly in the age cohort between comprised between 50 and 59, there was a clear-cut decrease in terms of a cardiovascular event. And there's a lot of trial, but let me skip this for the sake of time, showing that the earlier you do your menopause hormone therapy, the better it is. And this is the ELITE trial showing the carotid intima media thickness is much lower in those women who receive HRT when they're early after menopause. And it's not got worse when the women started later, but it's not prevention. It's just management. So to go towards conclusion, if we think about the specifics of metabolism and menopause, and we discuss about how we can improve metabolism, a part of it is not just hormones, of course, but the hormone can be a part of our strategy in those women who are more symptomatic and more metabolically impaired. But the issue is that whatever we do with the hormones, it needs to be continued long term. So adherence is very important. So we should be able to discuss all this information that I gave you together with all the others information which were not part of the presentation, like breast cancer risk, GSM, bone metabolism, not in terms of what are things that could happen, but mostly what are the benefits that you as a woman could, under receive throughout your life. So the take-home messages are that metabolic derangements and obesity have a profound impact during reproductive life and beyond menopause. We need to be good in identifying early women at risk to enact appropriate lifestyle and pharmacological preventive strategies. Awareness and long-term adherence to healthy lifestyle, of course, which is the paramount intervention and treatment, including hormones, are of key importance to prevent deteriorating health and quality of life. This is true for PCOS women, for obese young women during pregnancy and after menopause. And of course, after menopause, we have data on HRT showing that the metabolic impact is good, and women need to be empowered to understand how the metabolic risk is going to change throughout life and what are the treatment options. So thank you so much for listening to me. And I think we will have probably the discussion afterwards, right?
Yes, thank you, Tommaso, for that beautiful presentation, extensive, covering all our aspects and all our moment of women life. Then we will move on. I will invite Professor Andrea Giannini, who is associate professor at the Division of Obstetrics and Gynecology, University of Pisa. He is interested in gynecologic and reproductive endocrinology and menopausal medicine, and he dedicated to translational research on rat models in the field of menopause and neuroendocrinology of aging and the effect of menopausal hormonal therapy on neurobiology and neurotrophic factors involved in menopausal transition. He also dedicated himself to clinical study on endometriosis and endometrial and uterine precancer and cancer condition, and he will speak about on oncological impact of metabolic syndrome. Thank you, Andrea. Please, you have the microphone and you can share and start your presentation. Thank you very much.
Thank you, Professor Genazzani, for the opportunity to contribute to this interesting event. And thank you, Professor Simoncini, for having the lecture right before me. So I think it's a privilege to talk after him because he explained in a very comprehensive way what happened to the transition of a metabolic issue during the different period of women's life. If we talk about oncological impact of metabolic syndrome, I would like to focus on endometrial and breast topic. Anyway, I would like to focus also on endometrial pathology. As previously described by Professor Simoncini, is well known what happened to the visceral adipose tissue and the abdominal subcutaneous adipose tissue during the aging process of a women. So there is an increase of this kind of fat. And parallel to this metabolic change, there is something that is very interesting that happened across the aging process of women's life. There is a metabolic immune signaling impairment during the chronological and endocrinological transition in the midlife female biology, with an increase of fatty acid beta oxidation, and in general with an increase of the activation of oxidative stress in general. This lead to an impairment, a significant impairment of innate immune and adaptive immune response, and a deterioration of the glucose metabolism, parallel to an increase of fatty acid beta oxidation. So these are some biological aspects that are centered in our presentation. If we consider the reproductive factors at the basis of the oncologic transition to the normal endometrium to a preneoplastic and neoplastic lesion, it's important to note the an opposite estrogen theory. This is the basis that suggests that endometrial cancer risk is increased in those women with high plasma level of available estradiol or estrogen in general and low level of progesterone. It's important to note that the reproductive risk factors that increase the lifetime exposure to unopposed estrogen are, for example, the early menarche, late menopause, the mechanism of anovulation, the nulliparity, and the use of tamoxifen in some patients with breast cancer, that all the patients that must use this kind of drugs that can have some adverse event on endometrium. And if we look at the biological mechanism involved in the association of obesity and endometrial cancer risk, it's important to note that there are endogenous sex hormone steroids, insulin resistance and hyperinsulin mechanism, impairment of adipokines and inflammation that can be overexpressed sometimes, and genetic factor. So let's start with one of the most important concepts at the basis of this transformation, which are the obesity. Obesity is one of the first steps forward from a normal endometrium to a neoplastic endometrium. Obesity is a condition that is characterized by hyperestrogenic, hyperinsulinemic, and pro-inflammatory state. With this kind of condition, so obesity at different state and degree, there is the promotion of a proliferation and accumulation of some somatic genetic event that can subsequently evolve in malignant transformation. Parallel, there is a pro-inflammatory milieu in this tissue, with an overexpression of a C-reacting protein levels, interleukin-6 and tumor necrosis factor level, with a relative deficiency of protective immune cell types. Moreover, hyperestrogenic state means that the understanding the conversion to estrogen by aromatization is something that happens in the adipose tissue thanks to the aromatase enzyme. And at the end, if we talk about postmenopausal women, it's clear that these kind of patients show a natural progesterone deficiency. And this natural deficiency of progesterone contributes to an obesity-driven unopposed estrogen excess. So this is the leading theory that can lead to endometrial cancerogenesis. It's also important to focus and to point out the relevance of insulin resistance and hyperinsulinemia on endometrium. Insulin resistance and the state of hyperinsulinemia features obesity, diabetes mellitus type 2, PCOS, and there is a promotion of endometrial stimulation by increasing the bioavailability of both estrogen and AGF1 to the reduction of sex hormone binding globulin and AGF binding protein. So there is a direct and indirect activation of some pro-oncogenic pathway that Professor Simoncini explained very well right a few minutes ago, with an increase of endometrial proliferation. And sometimes this can explain a high incidence of diabetes and PCOS on, independently according to BMI. Moreover, there is a chronic increase of insulin level and IGF-1 activity that directly promote the cell proliferation and inhibit the apoptosis inside the endometrium, both in pre- and postmenopausal women. The insulins promote the tumor growth by binding IGF-1 and insulin receptor within the endometrium. And sometimes glucose may contribute to the tumor growth as a real energy source for the oncologic blast. On the other hand, insulin indirectly stimulates endometrial carcinogenesis by increasing the androgens. Androgens that are produced in the ovaries, and androgen can lead to a chronic anovulation and the progesterone deficiency as well as decrease the synthesis of sex hormone binding globuli by the liver. So the end of the process is the availability of estrogen can diffuse in the endometrium without a adequate counter-interaction. This is a very smart and interesting cartoon that summarizes what happened in obese patient and in patient with hyperinsulinemia in the ovaries, in the liver, in the adipose tissue, and the peripheral circulation. That all these kind of process lead to a reduction concentration of progesterone, sometimes chronic anovulation in young patients and perimenopausal women. The availability of estrogen with a relative hyperestrogenism, high level of insulin, the condition of insulin resistance, and the availability of growth factor that can act directly in the endometrial cells with reducing the function of apoptosis, increasing the cell proliferation by itself. If we want to move to the clinical issue of this topic, it's interesting to evaluate the independent risk factor for endometrial preneoplastic and neoplastic lesion. For example, the BMI. A BMI of 35 or more is an independent risk factor for the development of preneoplastic and neoplastic lesion of the endometrium, as well as the presence of polyp, the presence of polyp with abnormal uterine bleeding, of a personal history of Lynch syndrome, for example. And if we consider the BMI, it's interesting to note that every 5-unit increase in BMI, there is an association with a 54 higher risk to develop endometrial cancer. And all patients who show a BMI that is more than 40 have a 10 to 15% of risk to develop this kind of uterine cancer. It's not clear whether the weight gain during adulthood and aging or the body adipose distribution are more important than BMI, because this is an open debate. What is interesting is the association with the BMI and the type of endometrial cancer. For example, if you look at this slide, you can look at that the type 1 endometrial cancer, we can affirm that endometrioid adenocarcinoma, and adenocarcinoma with squamous differentiation, the overall risk to develop this kind of tumor is 1.5 in patient overweight, 2.5 class 1 obesity, and 4.5 in class 2 obesity, 7.1. This percentage are a little bit different in type 2 endometrial cancer, but the trend is the same. So it's interesting also to focus that in general, obesity appears to play a similar role as endometrial cancer risk factor for different ethnicity. And for example, patients with BMI more than 40 who develop endometrial cancer are more likely to have a less aggressive histology, are more likely to present early stage and low-grade histology, and the higher is the BMI is associated with the development of endometrial cancer at a young age, because you know that to 5 to 15% of patients with endometrial cancer are less than 44 years of age, 45 years of age. So in this view, another time, the distribution of adipose tissue does not appear to be a factor in endometrial cancer risk. But this is an open question. This is an open question because this is a very interesting study from Belgium, where the question is if there is a role of fat distribution in the origin of endometrial cancer. And the answer, sorry. Okay. Because BMI, we use BMI because sometimes it is an easily applicable indicator. But this kind of indicator not cover the complexity of fat distribution in visceral and subcutaneous compartments. So the group of research find that higher visceral fat percentage was a negative prognostic biomarker in non-endometrioid endometrial cancer compared to subcutaneous fat, which is important for estrogen production through increased aromatase activity. Anyway, the distribution of fat is still a matter of debate. Is not there are not robust literature in this view. What about the prenoplastic lesion and the association, for example, with obesity and metabolic syndrome? Even the endometrial hyperplasia with or without atypia are increased in patients with high level of circulating estradiol, but also high level of absent ovulation. So in patient with intermittent or absent ovulation, patient in a reproductive age with this kind of syndrome, or patient who underwent estrogenic replacement therapy without an adequate opposition of progestin. Is considering the prenoplastic lesion, is not important the amount of estrogenic stimulation, as well the duration. The duration of exogenous and endogenous hyperestrogenism is the most important factor for the risk of develop this prenoplastic lesion. So the duration of the stimulation is the most important topic. If we consider the risk of the development of prenoplastic lesion, we observe obese patient. We note that the patient with BMI more than 30 show a four-fold increased risk of to develop endometrial hyperplasia with atypia, and patient with a BMI of 40 show a 13-fold increased risk to develop endometrial hyperplasia with atypia. So it's a very important aspect, this one. Moreover, nulliparity and infertility are related sometimes to the condition of a prenoplastic lesion. Both are associated with chronic anovulation, obesity, and PCOS, because patients with this kind of syndrome, so chronic anovulation, PCOS, and obesity, often are patients nulliparous or with problem of fertility. And when we talk about endometrial hyperplasia, it is important to note that the most important aspect is the presence of atypia, because atypical hyperplasia, together with endometrial intraepithelial neoplasia, is a peculiar lesion that can evolve that can progress in endometrial cancer in up to 28% of cases, while hyperplasia without atypia have a progression up to 5%. So these are two different kinds of lesions. Considering the concept of adiposity in breast cancer, the flow is similar to the endometrial pathway. So you can see that there is a link between obesity and breast cancer, such that the patient with a BMI more than 30 carries a twofold increased risk of breast cancer. This is a pandemic problem that probably in the future can involve tens of millions of persons right now. And it is something that increases with age and with the expression of aromatases. This is the same process, pathological process of adipose tissue in endometrial pathology. Obesity have the same mechanism of for the pathology of endometrial and breast. If you can see the adipocyte tissue dysfunction, even in the gland, in the breast, can lead to hyperandrogenism, hyperestrogenism, inflammation, and increase of the concentration of a cytokine, hyperinsulinemia, and increase of leptin. All these kind of dysregulation of metabolic inflammatory condition can lead to a tumor initiation and the progression. So the mechanism is the same. What is important is to note that the impact. If you look at the additional case for 1,000 women due to the risk factor associated with the lifestyle, you can check that considering the increased number of breast cancer, you can find 14 cases if patients show an increased BMI of 10 units. But the most important aspect is that the weight gain after menopause, it means at least 20 kilograms, show an increase of 45 cases. And if you look at the use of menopause hormone therapy, there is a great number of patients that can have a negative biological impairment after the weight gain above all during the menopausal transition and in the postmenopausal period. So if we want to conclude, we can affirm that the dysmetabolism are an hyperestrogenic, hyperinsulinemic, pro-inflammatory state that per se is able to promote the endometrial proliferation, the accumulation of somatic genetic events, and then evolving in malignant transformations sometimes. So we have a lot of stuff to do for have a strategy for the primary prevention. So risk-reducing lifestyle and pharmacological intervention are, for example, the weight loss, the physical activity. These are all active action for the reduction of this oncologic risk. The use of progestin, inflammatory drugs, and insulin synthesizing drugs such as metformin in patients with metabolic problem or anovulation problem, maybe in a reproductive age. All these kind of intervention can be useful and proper as a strategy for primary endometrial cancer prevention. Moreover, we have to intercept patient at risk. So we must treat chronic anovulation in young patients, often associated with the condition of PCOS. To treat young patient with PCOS or chronic amenorrhea with several compound and molecule such as progestin or pill, something long-term action progestin. And above all, to treat also patients with perineoplastic lesion, both during fertile period and menopausal transition. So it's important to identify patient at risk, to prevent using drug and lifestyle change, to intercept the pathology at the beginning, an early diagnosis, the treatment. It's important to follow up in this kind of patient. Thank you for attention.
Thank you very much, Andrea, for that fantastic presentation on the importance of metabolic syndrome and impact of metabolic syndrome on oncological aspects and mostly for the endometrium. Then I would like also to invite Tommaso to join us, and then we will start the session. We have already received a series of questions in our question and answer. Tommaso, can you join?
Yeah, I'm here.
Yes, I'm sorry. Okay, thank you very much. Then we have a first question from Damodar Mangolatore Chini that is for you. Do you believe that polycystic ovary disease is genetically related? Means if mother has a PCOS, the daughter will have it.
Yes, of course. There's a lot of genetics in PCOS. This is well established. It's not a single gene. It's like with diabetes. So there's many similarities. Many other genes that predispose to PCOS, that are associated with PCOS, are genes that fall within the set of genes that have to do with metabolism, for instance, and it's a how do you say? It's a constellation of genes. So it's not one single actor, but it's several things that are anyhow absolutely inherited. So it's a very ethnic thing. So in some countries in the world, in India, in the Mediterranean area, you have a prevalence that is higher than in other places of PCOS, families where all the family members tend to be PCOS or diabetics or insulin resistant or obese. So it's there, it's clearly there.
Thank you very much, Tommaso. And then Andrea, you have a question on what is the most predictive risk factor for the oncologic evolution of endometrial perineoplastic lesion. What are?
Yeah, at the moment, BMI. BMI is one of the most important. Is an independent risk factor for the development of endometrial cancer, perineoplastic, but also for perineoplastic lesions. Anyway, the literature is not so robust, but the debate is open about the role of the fat distribution. So if you look at PubMed, we can check that there is a movement because BMI is at the moment we have a great literature, is an important literature, show that BMI is an independent risk factor, but probably the future will show that the distribution of fat will be another factor.
Thank you. And another anonymous would like to ask you, Tommaso, the role you have mentioned, the role of adiponectin for insulin resistance. Can you give some more details about that point?
Adiponectin is one of the many molecules that are produced by fat tissue, particularly by the visceral fat. It's a pro-inflammatory compound. It falls within the family of adipocytokines. So the molecules that are in between metabolism and inflammation, particularly in the cardiovascular system. And it's something that is tightly dependent on the amount of fat. So the more fat you have, the more adiponectin. And it interferes with insulin signaling because it makes the insulin receptor less efficient. So beyond many other metabolic effects. So it's one of the biomarkers that have been under investigation in the past few years that are part of the big family of compounds which make insulin work properly. In this case, less properly. Yeah.
Thank you very much. It's very important, this linkage between molecules originate were messages from what we are eating, how we are balancing, and what that can happen. And for that one, I have a question for you, Andrea, which is some data more on the effect of menopause hormone therapy on endometrial hyperplasia.
Yes, but data show that the MHRT are compounds that are safe on endometrium. Data that are against this kind of theory are very old data. When someone prescribe non-balanced therapy. So if you don't use a proper concentration of progesterone in patient with uterus, there you can have a negative effect of oncologic transition to endometrial, to neoplastic or perineoplastic or neoplastic lesion. On the other side, the therapy is a balanced therapy is proper for, there is no risk.
I have a question, Tommaso, for you, also for your role in the menopause world. This is also from Anonymous. We would like that you make your name. It's a very pleasant when we can mention the people. The question is that one. He follow your presentation about the impact in menopause, and he asked, but we will only give hormone therapy if the patient is symptomatic, right? Punto interrogativo. What about women more than 60 years? Punto, ecco, interrogative mark.
Yeah, this is true. So the role of hormone replacement is not an anti-aging or a preventive strategy for degenerative disorders. We know that the best way to prevent cardiovascular disease is to stay fit, to stay lean, to eat well. So this is what we need to tell our patient. And to be honest, we can substitute all of this by providing hormones after the menopause. But so hormones are and will remain as a therapy for symptomatic women. Then it depends to define on how you define the symptoms. So the problem we have is that many women are symptomatic but we tend to underestimate the impact of these symptoms. So it's perfectly okay to give HRT to women who are symptomatic, but it's even more okay to give HRT to every woman who has menopausal symptoms, even if they're not measured. Now, for the women over 60 years of age, it's absolutely okay to provide HRT over the age of 60. There was no guideline that says you should not do that. The only thing that is recommended by all guidelines, and I perfectly agree with that, is that the older the woman gets, the more the attention should be placed by the physician prescribing HRT in identifying conditions that could contraindicate. For instance, has this woman a higher risk of having a deep vein thrombosis or a pulmonary embolism? Has this woman already had a cardiovascular event? So these are conditions where you should be extremely careful and probably should not prescribe HRT. But if the woman is fine and she's healthy, and she has no contraindication, the age of 60 is not a limitation.
Thank you. And then we have two different questions, which I will try to combine all together, Andrea, for you, from Elena Rota and from Lor Moran Papunen. Elena Rota asks, when is necessary to treat patient with metabolic syndrome with metformin? Just obese or also the thinner? And also what is the dose?
No, okay. Metformin, we can add the metformin even not in obese patient, in all patient with insulin resistance or hyperinsulinemia, because as you show in the polycystic ovarian syndrome model, as I previously told, this is a risk that is independent. So we have to add the metformin for the metabolic problem, and then you can reduce the risk or even of you can reduce this kind of issue on the oncologic risk. So you have to underwent metformin in all these cases. So.
Thank you. And another anonymous question just for you, to Professor Tommaso. How do you balance the other than the cardiac benefits with hormone replacement therapy? How should we counsel the patients?
Well, it's a very big question, so it depends on the scenario we are talking about. So overall, if we make a very general statement, so getting out from very specific situations, the benefits of HRT largely outweigh the risks in every healthy woman between the age of 50 and 60. So if the woman has no specific conditions, I think that spending a lot of time in worrying ourselves and the patient for the risks of potentially breast cancer, which is basically the only potential risk of long-term use of HRT, is not that clever. Of course, it's fair to acknowledge that there's discussion on that, but we should be very sharp in saying that you are young, you are healthy. If you have to do HRT because you have symptoms, you will feel better. And what you will get out of HRT as a secondary outcome is you will get less myocardial infarction, less fractures, less cognitive impairment, and you will die less as compared to you yourself not receiving HRT. And this is only going to be true if you will do HRT for many years. If you actually start HRT for symptoms and you stop HRT after 1 year, it's not even worth discussing about benefits and risks. You will have no benefits and no risks. And the only benefits you will have is to treat vasomotor symptoms on the short term.
Very well, very nice response. And Andrea from Lor Moren Papunen, I already mentioned, another question related to metformin. Would you recommend to use metformin in a preventive way in the absence of prediabetes or diabetes to prevent the development of metabolic syndrome and or endometrial cancer in postmenopausal overweight or obese women?
No, because for as prevention, you must have the metabolic problem, so you must treat the patient. But considering the preventive approach, it's more important a lifestyle change, and so a diet, and for example, hormonal therapy, and so on. But you must add the metformin to the prescription only when you have a metabolic problem or a preclinical problem, but not only for prevention.
Thank you. And Tommaso, if you want to make comment also on the response of each one of the other, please do it. But I have a question from Mauricio Lorenzato. Would routine vaginal hysterectomy be a good option for obese patients using hormone replacement therapy?
No, I don't I don't see why, or better, or even because if an obese patient receives hormone replacement therapy in the form of estrogens plus progestin, because she has a uterus, her endometrial cancer risk will be decreased, heavily decreased. So there's no reason to think about something as aggressive as an hysterectomy. So no. So the answer is no.
Yes. Then I have another question I have, which, okay, this is from Agnieszka Mulkern. This is for Andrea, you can take. If patient is taking estradiol plus progesterone, Mirena, and testing progesterone is still low, certainly is still low because you cannot measure levonorgestrel.
No,
You can extra progesterone to reduce the risk of estrogen-dependent cancer.
No, because IUD with the levonorgestrel is effective in the prevention, the treatment of perineoplastic and neoplastic lesions, so in young and old patients. So you can, it's a good amount of progesterone, and we can check the action inside the endometrial cells. But we know the literature is there is a broad field of literature affirming the safety and the efficacy of this kind of therapy.
Okay. Then another question is from Miguel Diaz. Tommaso, would you recommend inositol also versus metformin?
Yeah, it depends on what you want to reach. So the role of inositol is, I would say, is popular in the setting of PCOS in younger individuals. So I don't think there's enough evidence to suggest that it's effective, for instance, for metabolic improvement in elder women at the menopausal transition or afterwards. The effect is different. Of course, we're talking about comparing a food strategy with a drug strategy, so with therapeutics. Of course, metformin is much more effective. If a woman is hyperinsulinemic and overweight, metformin would certainly be my first choice. I think it's a very safe drug, and it's certainly very effective in helping a woman lose weight and improve her your metabolic balance. Inositols are probably for those conditions that are more borderline, where you can provide a smaller help, and I think they are more appropriate for younger women who are not as metabolically impaired as themselves 20 years afterwards.
Thank you. And Andrea, Denise DeFay, she's from Uruguay. She's asking, do you consider annual transvaginal ultrasound a good prevention of endometrial cancer in asymptomatic women with risk factors?
No, for endometrial cancer is not a routinary prevention. Ultrasound examination could be useful, helpful, but is not a prevention. It is for ovarian cancer, but not for endometrial cancer.
And what do you suggest?
I suggest the right lifestyle and I think a fast interception of the most important symptoms, such as bleeding or something like that. Anyway, once here is important, a gynecologic consultation, but there is no data that ultrasound examination can reduce the risk of perineoplastic or neoplastic lesion in a general population. So there is no prevention. The prevention is to reduce the risk factor, so obesity or something like that.
Thank you. Mostly impact on lifestyle, which is the most difficult because, you
Yes,
know.
but is to treat
Yeah.
an ovulation, to treat chronic anovulation, to treat PCOS, to treat all these risk factor, independent risk factor.
Thank you. Okay, then now we have no more. We have just another question, and which, and then the question is, Tommaso, how long would you give metformin, and which dose?
So the dose varies, so it depends on the needs of a patient. And of course, I give it for granted that we are not talking about women with diabetes. So if you have diabetes and you use metformin, of course, the amount of metformin or other drugs you give depends on reaching the good glucose, peripheral glucose target levels. Here we're talking about person who are not diabetics, so we don't have a precise number to reach, okay? So we are probably providing metformin in trying to help women lose weight. So I think that the most practical answer is I would give it as long as it's needed in the path of that woman in increasing her physical activity and being effective with her diet into losing weight. So as long as the woman loses weight, she will probably be less dependent on metformin because she will have less abdominal fat. So she will become more insulin sensitive. So there is a certain time when one could consider decreasing the dose of metformin. And about the dose, of course, the minimal dose is 500 milligrams twice a day at principal meals, be it breakfast and dinner or lunch and dinner, so it depends. But one can reach up to doses like 1.5 or 2 milligrams a day. So there's also different types of administrations. There's retard, absorbable metformin, which is sometimes more useful for people who have diarrhea, strong diarrhea with metformin. So it really depends. So the outcome is for me losing abdominal fat. So and of course to this extent, I don't think that metformin alone is okay. Metformin should be a part of a strategy that combines diet, physical activity, and metformin.
Thank you. Tommaso, there is another question from Shadi Vakili, I think for you, because you wrote a paper on that one. This, does estetrol plus progesterone for menopause hormonotherapy have a lower risk of breast and or endometrial cancer in this patient than estradiol plus? It is important is the concept of the estrogen and the concept also of the progestin. Please, if you can.
Yes, absolutely. So for endometrial cancer, let's take it out of the discussion. So whatever estrogen you use, be it any type of estrogens used for menopause hormone therapy, like conjugated equine estrogens, estradiol, or estetrol, when it will become available for menopausal hormone therapy, if you have enough progestin, any type of progestin that is approved for menopause, then you have no risk of endometrial cancer. Okay, so this is easy. For breast, we don't know. There's a lot of indications that estetrol could be less effective or actually even safe for the breast. But this evidence comes from preclinical models. So animal studies, studies in isolated breast cancer cells, and a couple of studies on patients with advanced or with breast cancer, where biochemical markers of proliferation activity of breast cancer was examined. So the evidence that we have so far is not enough to make any statement yet on whether estetrol would be safer than estradiol on breast cancer. It could be, but we need to test it.
Thank you very much. And then now there, I think we can use as our last question. We have two questions that I put together, which are touching what is the international news and problems and attention related to overweight, obesity, and so on, which are, I mentioned two products. One is semaglutide, the other is tirzepatide on overweight. Then what is the role of, if we are already using something very new? I would like to have your comment about this new approach.
Yeah, I'll take that. So these are extremely effective drugs. So there's very good evidence that per individuals, so men and women who are obese and who use these drugs will be able to lose up to 20% of their weight, depending on the studies, between 10 and 20% of the weight. There's a lot of questions onto what happens when you stop using them, because most of the studies show a quick regain of weight. So there's a discussion on whether these should be drugs that need to be taken forever in order to keep the loss of weight under control. And so far, there's no indication that this would be unfeasible. So any specific safety issue. But of course, the data is very sparse, because the indication is really to prevent cardiovascular disease in obese persons with diabetes. So far, this is the indication. The indication might be broadened, but the cost of these drugs is such that there's no guideline on to who should really use it. So if it's okay only if you're obese or even overweight persons but it seems to work in all the conditions. So this is well known in those countries where people are heavily buying these drugs and using it outside of medical indications to keep the weight under control. So I think this is a very important family of new drugs, and in the future, I think there will be of paramount importance also for us in gynecology. Yes.
Thank you, Tommaso. I think also we will speak about these topics in your next congress of ISGE that you will do in Rome, and then we are at the end, and then I would like to ask both of you to make a general comment as a final message that you want to bring. We will start with Andrea. He was speaking the second, and then you will terminate, Tommaso. Andrea, please, you can give a comment about.
Take-home message is to the prevention. So the prevention and the early detection and treatment of risk factor are the most effective therapy for the transition to a normal endometrium to a pathologic endometrium with a prenoplastic, neoplastic lesion in a patient with obesity or a metabolic syndrome. And so the prevention lifestyle is already one of the most important aspects in this kind of patient.
Thank you very much. And then Tommaso?
Well, I think Andrea said it very well. So the impact of being fat, being obese, overweight, with all the different gradations of gradings of severity is profound. And for women particularly, it doesn't just carry an impact on long-term cardiovascular risk or risk of diabetes or on risk of cancers, which is what we men experience. But there's also a heavy reproductive impact. So women have also an impact on ovulation, on fertility, on peripheral symptoms, which are very important during adolescence, like skin disorders. Pregnancy is heavily impacted. Abnormal uterine bleeding are associated with higher loads of fat. So women, I would say, that carry even more problems while being obese than men, because this fat interferes heavily with the hormonal axis and makes their function less efficient. So I think women tend to be also luckier than us, so they tend to be more easily able to keep their weight under control, but it's not true for all of them. So we need to be able to help them when this is not true.
Certainly. Thank you, Tommaso. Thank you, Andrea. I thank both of you of this fantastic webinar on metabolic syndrome. And I would like to have the conclusive slides from your session. Is first of all, for everybody, please save the date. Remember you that Rome, then 4-7 March 2026 in Rome at the time, we will have the event for the 22nd World Congress of Gynecological Endocrinology in the years of the 40 years of our fantastic society. Thank you, Tommaso. Thank you, Andrea.
Thank you.
Thank you. Thank you.
I wish all our best for the end of the year, and then for with the all hopes that we will have also a fantastic 2025. Thank you very much for being with
Appreciate
us.
it.
Bye bye, everybody.
Bye.
Bye bye. See you soon.